Hello everyone, my name is Ashish Shrivastava. I am a second year pediatric resident and I'm delighted today to take this opportunity to present my poster on my research titled Longitudinal Assessment of Exercise Capacity and Pulmonary Function in Patients with Detransposition of Great Arteries who underwent mustard palliation. To begin with, as we all know, TGA is a cyanotic heart disease where there is ventriculo-arterial discordance with or without atrioventricular discordance. In the past, we used to perform mustard palliation for TGA patients using a two-way baffle. Since the right ventricle works ventricle, therefore it is predisposed to systemic right ventricular dysfunction. So cardiopulmonary exercise stress test is helpful and assist with informed clinical decision making in this high-risk population. So this brings us to our study objective, which are as follows. First of all, our primary objective was to assess longitudinal changes in the exercise capacity in the study population with mustard palliation. And then our secondary objective was to analyze the role of abnormal lung physiology on exercise capacity. We use the following methods to achieve our study objectives. This single-center retrospective study included mostly adults with DTGA, status post-mustard palliation, who underwent serial cardiopulmonary testing at least on 2 separate occasions. Initial and latest tests were analyzed. Patients with other congenital heart defects and incomplete data were excluded from the study. Demographic data and CPT parameters were also collected. The CPT parameters included in the study are, first of all, peak oxygen uptake or peak VO2, which is an indicator of maximum aerobic capacity. Second is the VO2, which was normalized for age, weight, height, and gender. And the third one is percentage of oxygen pulse. Peak oxygen pulse was calculated by dividing VO2 by the maximum heart rate. Oxygen pulse is also a measure of the oxygen consumption per heartbeat and may provide information about the prognostic importance of the exercise capacity with respect to cardiovascular diseases and all-cause death. The fourth parameter was metabolic equivalent or METS. Abnormal exercise capacity was defined by a VO2 of less than 85%. The spirometry parameters were also analyzed, including FEV1 percentage, FVC percentage, and the ratio of FEV1 to FVC. And based on these parameters, we categorized the patients as normal, which were defined as the one with FEV1 more than 80%, FVC more than 80%, and the ratio of FEV1 to FVC more than 70. And we defined abnormal pulmonary function test as FEV1 percentage less than 80% or FVC less than 80% or the ratio of FEV1 to FVC less than 70. We use pair t-test and chi-square test as appropriate to compare various exercise and spirometry parameters between the initial and follow-up tests. Let's take a look at some of the tables we prepared from our data and what we figured out in the analysis. Then we will move to the results section. So the first table here is a comparison of various parameters at the initial and latest CPT. We included exercise as well as demographic parameters. Now looking at the parameters specially focused in the study like VO2 or maximum oxygen consumption, heart rate, METS or oxygen pulse, you will notice that there are changes in the initial and latest values, but the p-value for most are than 0.05. Coming now to table number 2, where we compared the various parameters for normal and abnormal pulmonary function testing. Our parameters under focus do show changes and some of them show a significant change as well, like percentage FVC and ratio of FEV1 to FVC. Coming to our third and the last table, where we just made a 2x2 table for exercise capacity and pulmonary function testing at the initial CPT. Now let's see what results we could get from our analysis. First of all, the cohort included 63 adults who underwent initial and latest CPT at a mean age of 29.8 years and 32.8 years respectively. Majority demonstrated an abnormal exercise capacity that was 71%, abnormal pulmonary function testing that was 76.2%, or both abnormal exercise and pulmonary function testing, which included 55.6% of the patient population. There was no significant interaction between exercise capacity and pulmonary function testing, and the short-term follow-up revealed no difference in various exercise or pulmonary function parameters. During the discussion of these results, what we concluded was abnormal exercise capacity and pulmonary function testing are quite prevalent amongst adult survivors with DTGA with mustard palliation, and in this cohort with baseline compromised pulmonary function, short-term follow-up did not uncover further deterioration. So to conclude, although we did see changes in the various parameters, there was no significant deterioration in the exercise capacity or the pulmonary function testing due to baseline decline or compromise. That's all from my side. Once again, thank you so much for the opportunity.